Next, we have Perioperative Outcome and Fellow Experience during Minimally Invasive Bariatric Surgery Training by Dr. Mostaedi from UC Davis.
I would like also to encourage people to use the electronic submission of questions.
I would like to thank the SAGES committee for allowing me to present my data. We evaluated the perioperative outcomes during the learning phase of a bariatric surgery fellowship training. I have no disclosure. So previous comparison studies of the learning curve and fellowship training programs of bariatric surgeries have demonstrated that the learning curve is approximately 75 to 100 cases required to transition to practice with diminished perioperative outcomes. In terms of large statewide and national database analysis comparing fellowship and pre-fellowship programs in bariatric surgery, there hasn't been shown an increase in adverse outcomes during this time. So currently, there's no study that has evaluated the outcomes by fellows during the course of their learning curve. We have observed that the operative performance of fellows during minimally invasive bariatric surgery training dramatically improved during this time. We sought to determine if the perioperative outcomes are affected by during this change in level of experience during this 1 year. So this is a retrospective review of a prospective database over a 6-year period from 2008 to 2014 at a single academic center. The primary bariatric operations included the Roux-en-Y gastric bypass, the vertical sleeve gastrectomy, and the adjustable gastric banding. Cases with additional or secondary operations were excluded. So for example, if a hiatal hernia repair, cholecystectomy, or ventral hernia repair were done, these cases were excluded. Also, fellow were listed as the primary surgeon with the assistant as the senior surgeon. At our institution, during the first month of training, there's a standardized protocol where there's a skills lab with operative assistant with the goal of transitioning performing the entire bariatric operation as the primary surgeon. So with demographic, clinical, and perioperative data, this was evaluated. The minimally invasive bariatric operations included total laparoscopic and robotic-assisted laparoscopic. In order to evaluate the change in perioperative outcomes, we divided the group into two. Group A would be fellows during the first 6 months of training, and Group B would be the second half of their fellowship year. In terms of the total number of cases, 984 cases were done. In the first half, 479 were done. Second half, 505. As you can see in the first bar graph, more than 2/3 of the operations were Roux-en-Y gastric bypass, and when you look at each group, more than 70 to 90% of the operations were done total laparoscopically. So when you look at the gender, as we all know, approximately 80% of the study group were women. There was no difference in gender between the two groups. The mean age were the same, except that in the vertical sleeve gastrectomy, this was slightly significant, being 3 years older. In terms of BMI, they were all pretty much on average class 3 obesity with no difference between the two groups. In terms of comorbidity assessment, previous abdominal pelvic operations, there were no difference between the two groups. In terms of ASA classification of 3 or higher, there was no difference between the two groups except for a higher number of these patients in Group B gastric banding patients. And in terms of pre-existing diagnosis of metabolic syndrome, there was no difference between the two groups. As you can see here, in terms of operative and anesthesia time, there was a trend in decrease in the latter half of training. This was statistically significant in the Roux-en-Y gastric bypass and the gastric banding. This was not statistically significant in a vertical sleeve gastrectomy. And again, in this table, you could see that the improvement in operative efficiency in terms of operative and anesthesia time. In terms of additional perioperative data of estimated blood loss and length of hospital stay, again, there was no difference between the two groups. Now, looking at the 30-day major complication rates, when you look at Group A and Group B, there was no difference between the two groups. When you look at the splenic injury, hemostasis was achieved, and no one in these cases required a splenectomy. In terms of dehydration, you could see here these were patients who required hospital admission for fluid resuscitation. There was about a 1.5% rate for requirement for TPN. In terms of infection, this was the total for surgical site infection and surgical related infection for UTI and pneumonia. And in terms of miscellaneous, these were kind of infrequent observation of complications such as pancreatitis, kidney stones, pulmonary edema, and et cetera. Overall, you can see here the total major complication rates, reoperation rate, and mortality rates were no different between the two groups. And when you look at the overall in the study, you could see that they were low and very similar to recent data. When you look at the Roux-en-Y gastric bypass only, the one-year complication rates for internal hernia was approximately 0.3%. and 2.4% for marginal ulcer formation. In this entire group, we did not observe one anastomotic leak. So at our institution, the overall perioperative outcomes were not adversely affected between the two groups. The major complication rates, mortality rate were low, similar to recent data. We know that the Roux-en-Y gastric bypass is a complex operation, and our study shows that there is an improvement in operative efficiency observed in the latter part of training. Our study, with limitations, this is a retrospective review, and there are heterogeneity in terms of MIS experience prior to the beginning of their fellowship. Thank you.
The paper is open for discussion.
So I have a question. Usually when you do a learning curve study like that, you like to compare to a level of proficiency because you really didn't achieve a plateau. And it sounds like you have a protective database. Why didn't you take cases that were done by attendings, assumed to be masters, and see how close at the end of the fellowship year you were to expert levels?
Well, I think at our program at UC Davis, I would say that the fellows start very early in terms of training of becoming the primary surgeon. And we wouldn't have enough cases where the attending are the primary surgeons to be compared to this group. We do have data that goes back to 2002, and I could look into that. That would be a very good point.
Moriyama?
Ken Moriyama from Abington, Pennsylvania. So you have a skills curriculum, I think you said, before you get to the OR as a fellow. Is that a hard stop if the fellow can't perform the skills to a certain level of?
Yes, and this goes back to the heterogeneity of the skill sets of the fellow when they start their training. Each fellow will get a lab trainer and have video slides to practice at home so that they come up to speed in terms of the technical aspect.
And who makes that determination?
Well, one of the staff actually makes all the videos and provides the trainer, and they will sit down and review because you could actually record yourself because it's on an iPad or a video monitor that you could record yourself. So the attending will review your skills when you practice at home.
Okay, and then the second question I have has to do with, we all know that the attendings are supposed to be there for all critical portions of the operation. Did you look at the percent of time attendings were actually scrubbed on the cases, even though the fellow is the primary surgeon?
For all of these cases, the attendings are present from beginning to end.
Are they scrubbed from beginning to end?
Oh, yes.
They are scrubbed from the
I
whole-
mean, there are maybe like brief moments where the fellows are gaining access, but in terms of the actual start of the operation, they are there from beginning to end.
Okay, thank you.
I have a question. With sleeve gastrectomies becoming more and more popular, and I think fellows having less and less exposure and experience in Roux-en-Y gastric bypass, I would imagine the study will look very different in a few years if you did it then. Ted, did you notice any difference? Yours was for 6 years. Any difference between the first half and the second half? Or did you look at that at all?
You know, I did not specifically look at that, but I do know that at our institution, we still truly believe, meaning the staff and most of the people who come out of the training, believe that the bypass is still the primary standard. So in general, at UC Davis, about, I would say, 50 to 65% of the time, it's still the bypass operation. So, you know, in terms of the fellowship experience, they do get a decent number of experience in the bypass operation. Thank you.